everyone, and welcome to today's podcast. I'm Reem, and in this episode, we're focusing on oral squamous cell carcinoma, specifically how it develops, step by step, at the cellular and molecular level. To guide us through this process, I'm honored to be joined by Professor Nathir, a pathology expert. Thank you for being with us, Professor.
Thank you, Reem. I'm glad this episode focuses on pathogenesis. That's where OSCC truly becomes understandable.
Before we dive into the details, let me ask, why is understanding the pathogenesis of oral squamous cell carcinoma so important?
Because OSCC is not an abrupt disease. It develops gradually through accumulated genetic and molecular changes. Understanding this explains the sequence of events, from exposure to risk factors to genetic mutations, and finally to invasive cancer.
So we're dealing with a biological continuum, rather than a single transformation.
Exactly. And that continuum begins long before we see a visible lesion. So understanding the pathogenesis helps clinicians identify high-risk patients, recognize potentially malignant disorders early, and choose appropriate prevention and treatment strategies.
That really puts things into perspective. Knowing how the disease develops helps us intervene before it's too late. Now that we understand why pathogenesis matters, let's talk about the etiological factors. What are the main causes behind oral squamous cell carcinoma?
Oral squamous cell carcinoma is multifactorial in origin. The most important etiological factors include tobacco use, alcohol consumption, areca nut and betel quid chewing, and oncogenic viruses, particularly human papillomavirus, or HPV.
Is tobacco still considered the biggest risk factor?
Yes, absolutely. Tobacco, whether smoked or smokeless, introduces carcinogenic substances that cause DNA damage in oral epithelial cells. When combined with alcohol, the risk increases significantly because alcohol enhances mucosal permeability to carcinogens.
And what about areca nut chewing?
Areca nut contains alkaloids that stimulate chronic inflammation and fibroblast activity, leading to conditions like oral submucous fibrosis, which is a well-known potentially malignant disorder.
Are there any other contributing factors?
Yes. Chronic irritation, poor oral hygiene, nutritional deficiencies, genetic susceptibility, and immunosuppression can also play a role by increasing epithelial vulnerability to malignant transformation.
So essentially, these factors create a biological environment that favors cancer development.
Exactly. They initiate and promote genetic alterations that eventually lead to malignant transformation.
We've discussed the risk factors, but how do these actually cause cancer at the cellular level? What kind of genetic and molecular damage occurs in oral squamous cell carcinoma?
At the core of OSCC pathogenesis is accumulation of genetic mutations in oral epithelial cells. These mutations affect oncogenes, tumor suppressor genes, and DNA repair genes, disrupting normal cell regulation.
Which genetic changes are most commonly involved?
One of the earliest and most important events is mutation of the p53 tumor suppressor gene. Normally, p53 halts the cell cycle or induces apoptosis when DNA damage occurs. When p53 is inactivated, damaged cells continue to proliferate.
So the cell loses its protective checkpoints?
Exactly. In addition, there is overexpression of oncogenes such as EGFR, which promotes uncontrolled cell proliferation, and cyclin D1, which drives cells rapidly through the cell cycle.
What about cell death mechanisms?
Apoptosis is often impaired. There is upregulation of anti-apoptotic proteins like BCL2 and downregulation of pro-apoptotic pathways, allowing abnormal cells to survive longer than they should.
Are there changes beyond just cell proliferation?
Yes. As the disease progresses, tumor cells acquire the ability to invade and metastasize through loss of cell adhesion molecules like ecadarin, increased matrix metalloproteinase activity, and induction of angiogenesis via factors such as VEGF.
So OSCC is really the result of multiple genetic hits over time.
Exactly. It's a multi-step, multigenic process where repeated molecular damage eventually transforms normal epithelium into invasive carcinoma.
One term that often comes up in oral cancer is field cancerization. What does this actually mean?
Field cancerization refers to the presence of a wide area of genetically altered oral epithelium caused by long-term exposure to carcinogens like tobacco or alcohol. Even though the mucosa may look clinically normal, the cells already carry genetic mutations.
So the cancer doesn't arise from just one isolated cell?
Exactly. Multiple areas within the same field can undergo malignant transformation independently. This explains why patients with OSCC have a high risk of multiple primary tumors and local recurrences.
That also explains why complete surgical removal can still be challenging.
Yes, if the surrounding field remains genetically altered, new cancers can develop even after treatment of the primary lesion.
Before oral cancer actually develops, are there any warning stages we should be aware of?
Yes. Many cases of oral squamous cell carcinoma are preceded by potentially malignant disorders, or PMDS, such as leukoplakia, erythroplakia, oral submucous fibrosis, and lichen planus.
What makes these lesions dangerous?
These disorders often show epithelial dysplasia, which represents disordered growth and maturation of epithelial cells due to underlying genetic damage.
So dysplasia is a key histological marker?
Exactly. The severity of dysplasia, mild, moderate, or severe, correlates with the risk of malignant transformation. As dysplasia progresses, the likelihood of invasion increases.
So identifying these lesions early can really change outcomes.
Absolutely. Early detection and monitoring of PMDS is critical in preventing progression to invasive carcinoma.
At what point does dysplasia actually become cancer?
When dysplastic changes involve the full thickness of the epithelium, without breaching the basement membrane, the lesion is termed carcinoma in situ.
So it's malignant, but still confined?
Exactly. The critical step occurs when tumor cells breach the basement membrane. At this point, the lesion becomes invasive oral squamous cell carcinoma.
What allows the cells to invade?
This involves loss of cell adhesion, degradation of the basement membrane by matrix metalloproteinases, and increased tumor cell motility. Once invasion occurs, the tumor can access blood and lymphatic vessels, enabling metastasis.
So invasion marks a major shift in disease behavior.
Absolutely, it transforms a localized epithelial lesion into a potentially life-threatening malignancy.
OSCC becomes invasive. What happens next?
The tumor continues to grow, invade nearby tissues, and can spread to lymph nodes or distant organs. Its behavior depends on additional genetic changes and how aggressive the cells become.
So the earlier we detect it, the better the chances of controlling it.
Exactly. Early recognition, monitoring potentially malignant lesions, and understanding how the cancer develops can dramatically improve outcomes.
That wraps up our discussion on OSCC pathogenesis. Thank you so much for sharing your insights with us today.
It was my pleasure. I hope this helps everyone understand why early detection and awareness are so important.
Absolutely. Thank you again for joining us.